Good afternoon, everyone, and welcome to this briefing session on Fit for the Future. In this session, we're going to concentrate more on the Acute Medical Take proposal. My name is Simon Lansley. I'm Director of Strategy and Transformation at the Hospitals Trust, and I'll just ask my colleagues to introduce themselves as well. So, Ian, please.
Thanks, Simon. I'm Ian Shaw. I'm a medical gastroenterologist and Chief of Service for the Medical Division.
Thank you. And Rob?
Good afternoon. I'm Rob Stacey. I'm an ED consultant. I'm the clinical lead, and that means I work in our two departments, both in Cheltenham and in Gloucester.
Great. Welcome, and thanks for making the time today, guys. So, as I said, this session is around acute medicine. It's an opportunity to hear a bit more about the proposal within acute medicine. And also a bit of context around the Fit for the Future programme. I'm hoping people that are watching today have had a chance to see some of the materials online, hopefully attend some other sessions. You will know that there's a number of live sessions we've been running on Gloucestershire Live as well, and the hard copy booklet you may have seen, and also there's been a recent leaflet drop through the doors of people living in Gloucestershire. So we're trying all the ways we can to reach out and encourage people to engage in this process. So we will use a combination of videos, some slides, and then we've had some questions submitted ahead of today, but there's also an opportunity to submit questions as we go. So across the bottom of the screen shortly, you'll see a link to Slido, so a web page where you can submit questions, and we'll keep an eye on those and we'll pull those into the session as well towards the end. So we'll start off with an introductory video from our medical director, and then we'll come back and summarise the key points of those and then get into the detail. So can we run the video, please?
Our ambition is to provide world-class, leading-edge specialist hospital care for our patients. Our expectations of healthcare, the demands on the health services, and the incredible progress made through science and technology have dramatically changed the environment that we're operating in. This means that we need to do some things differently. Thanks to the great work of NHS and care staff, we're well on the road to outstanding, but there's more to do. That's why we've been involving staff, patients, local people and the public in looking at a number of services and potential solutions. Following extensive engagement with staff, partners and the public, which included a citizens' jury and a solutions appraisal in public, we're now preparing to consult on a number of options for some services across our sites. We will use a variety of methods and approaches, including a virtual online consultation. The aim is to improve health outcomes, reduce waiting times and the number of cancelled operations, and ensure people see the right specialist to meet their needs 24 hours a day, 7 days a week. It's important that there are always strong and safe staffing levels across our services. We support joint working between related services to reduce the number of visits people have to make to hospital, and we attract and keep the best staff in Gloucestershire. For our services, it's about developing our Centres of Excellence approach, which reflects the way a number of services are already concentrated in one place, such as cancer care in Cheltenham and children's services in Gloucester. For our hospitals, it's about developing to two thriving, vibrant district general hospital sites in Cheltenham and Gloucester, with strong identities, both providing world-class leading-edge treatment. The potential solutions we outline in Fit for the Future consider whether one hospital should focus more on emergency care and one hospital should focus more on planned care and oncology. We believe this could help to ensure that the right facilities and specialist staff are always available to give people the best treatment and care. It could reduce the number of planned operations cancelled when beds or operating theatres are needed for the most urgently unwell patients. We want to strike the right, but often difficult balance between having two world-class centres of excellence in Gloucestershire and providing local access to services. There are no proposals to close Cheltenham A&E or to change the current staff arrangement, which includes consultants, doctors, nurses and allied health professionals. Full facilities for resuscitating, stabilising and treating patients would continue to be in place. Last year, we ran a comprehensive programme of engagement, and together with you, we explored the opportunities and challenges of developing specialist hospital services. We developed ideas and potential solutions for change and designed the criteria we would use to assess those potential solutions. We now want to consult with you about how we could organise some specialist services. Acute medicine, gastroenterology inpatient services, general surgery, which means emergency general surgery, planned lower gastrointestinal or colorectal surgery, and planned day case surgery. Image-guided interventional surgery, sometimes called IGIS, including vascular surgery, and trauma and orthopaedic inpatient services. For more information, please visit onegloucestershire.net or register with our new engagement platform, where you can share your views, experiences and ideas about health and care services at getinvolved.gloss.nhs.uk.
Great. So hopefully that gave you an introductory into the wider Fit for the Future programme. I just wanted to pick out a few key points really of the messages in there, and then we'll come on to talk a little bit more about acute medicine. So the overarching vision is a single hospital split across two sites, so one in Cheltenham and one in Gloucester. And it's about having the specialist care and expertise you need on hand. So whether you're coming to us in emergency, so life or limb threatening surgery, or whether you're coming to us on a planned basis, or in particular around cancer care, for example, that all the teams, all the services you need are available on those sites. Some of you may be aware of the NHS long-term plan, and within that's promoting a greater separation of emergency care and planned care. And this is our sort of interpretation of that long-term plan, and it's about making that, turning that into delivery. So it's a greater separation across the site. So Cheltenham General would focus more on planned care and cancer care, and Gloucestershire Royal would focus more on emergency care, paediatrics and obstetrics. But really important to note, this is not a purist model. So what we're not saying is all planned care at Cheltenham and all emergency care at Gloucestershire Royal. And you see that in our commitment we've made externally around Cheltenham General Accident and Emergency, for example, which will revert to its pre-COVID state of being consultant-led in the day and nurse-led at night. And similarly, we've made a commitment to maintain a 24/7 critical care unit at Cheltenham General as well. And that's to continue to support the complex elective and cancer care surgery that we would deliver on that site. So I just wanted to make that point around it's not a purist model. There will continue to be emergency provision at Cheltenham, and there will continue to be an element of planned at Gloucestershire Royal. And this is kind of building on some of our previous reconfigurations. So you may be aware, in the past that we have centralised paediatric surgery, for example, paediatric care to Gloucestershire Royal, gynecology to Gloucestershire Royal, oncology and urology to Cheltenham General, for example. But in most cases, the way that services are configured across our two hospitals is down to history. So when the trusts merged back in 2002, the same services were on each site, and it's just through time that those services have maintained there. So what we're saying through this programme is this is an opportunity to look afresh at how we use those two sites, take into account things like the NHS long-term plan and other guidance and best practice, which I'll talk about, to create, here's how we think we should use those sites for the next 10 to 15 years. And that's the period of the Fit for the Future programme. So you'll hear us talk about this concept of a centre of excellence, and on the screen now is a couple of bullets of ways you can describe that centre of excellence. But if I try to bring it alive a bit through emergency care. So if you imagine life or limb threatening emergency, so you, a member of the family, come to the hospital, and we're saying in that instance we would want that to be Gloucestershire Royal. And the reason we say that then is if we centralise those services onto a single site, it means you have access to the right specialty teams, facilities and equipment 24/7. So all co-located in one place to provide that rapid senior assessment. We can get treatment plans started to give the best chances of survival and recovery. We also think it's an opportunity to repatriate some activity elsewhere. So, for example, at the moment, if you live in Gloucestershire and you have a heart attack in the middle of the night, the chances are that you would end up travelling down to Bristol to access the services of that team. By combining it onto a single site, we think we can provide that in Gloucestershire, so to avoid that travel out of area. And then on a planned care basis, so if we separate the delivery of planned care away from that emergency site, what evidence shows is that reduces the competition for beds, theatres and diagnostics. So if you imagine you've got both emergency activity coming into a site alongside planned care and cancer care, in extreme pressures, so particularly over winter, for example, those same groups of patients are competing for access to those same resources. So if we can take away the planned care activity, we get reliable access to beds, to theatres, to diagnostic equipment. So it means that, we reduce the number of cancellations, for example, and our teams get reliable access to that kit and equipment. So again, it reduces wait times and it improves outcomes. So that's an explanation to try and bring those the two sites up to bring them to life. If we do that, we think we can continue to improve health outcomes for Gloucestershire residents, reduce waiting times and ensure fewer cancelled operations. There's nothing there's nothing worse than having to phone up and tell a patient that their operation's been cancelled, or a family member that their operation's been cancelled. So we think with this greater separation, we can reduce that. Getting timely access to decision making and seeing the right specialist first time. There's a really good example within emergency general surgery where there are two teams that provide the emergency general surgery rota, for example, a colorectal team and an upper GI team. And at the moment, our emergency general surgery services, they both support that rota. So you could come in and see an upper GI consultant and their team will look after you, but it may be that you have a colorectal issue. By combining those teams and putting it onto a single site, then we have 7-day access to both those teams. So if you need the skills and support of the colorectal team, then they're available 7 days a week and you see them first time. It will significantly help us improve staffing levels. So you can imagine having services duplicated on two sites where there are gaps in the rotas, that can result in some of our consultants stepping down into registrar rotas. And it can result in us relying on temporary staff or agency staff to fill some of those gaps. So centralising those teams onto a single site, it provides more robust rotas. So people are doing the roles that they're employed to do. And it's also permanent members of staff that are delivering that team there. So they're familiar with the hospital, the IT and the support functions. It's not only about the configuration of services. So if we create the centres of excellence approach, we think it will help us continue to attract the best staff to come and live and work in Gloucestershire, and to hold on to those staff. So currently there are services that are only provided, say, in Birmingham, Bristol and Oxford. The cardiology example was just one. But if we can provide that within Gloucestershire, then we can retain staff, give them further opportunities to grow and develop, and that's a key part of the proposal. I didn't want you to think that we've just sat in a dark room and come up with these proposals. So there, I mentioned the NHS long-term plan as one bit of guidance that's informed this, but the blocks on screen at the moment just show the wide range of best practice from the Royal Colleges to King's Fund to papers from NHS England. The Getting It Right First Time programme people may have heard of, have all informed these proposals. And just to pick out a couple, particularly the South West Clinical Senate. So before we were able to come out to public consultation on these options, we had to go through a really fairly rigorous check with a group of clinicians that are outside of Gloucestershire, so doctors, nurses, social care, who kind of interrogated the models, the approaches, and just making sure that we had taken into account what's going on nationally and internationally, but also to make sure that these proposals were deliverable. So we only can come out to consult on options that we can deliver within our trust. So that was a key checkpoint for us, and we went through that in August, September time. But also the options have been informed by discussions externally. So some of you may be involved in some engagement sessions that we started last summer actually, so ran from August all the way through to February. where we talked about the concept of centres of excellence and how that's been informed, and started to share some of our early thinking. And from those discussions, it's really hard to argue against the centre of excellence, isn't it? But we got a real strong pushback or support from the public around, actually, we like what you've done in oncology, for example, so centralising that service onto the Cheltenham site, and we can see the benefits in other areas around urology and paediatrics. So to roll that approach out to other specialties was really well supported, as was the benefit of repatriating activities. So Gloucestershire patients are treated within Gloucestershire. So the outcome of the last 18 months, 2 years work, those of you that have had time to read through the booklet, these are the services that we're now asking for feedback on. So if I look at the Gloucestershire Royal site first, so the column on the left, under the proposal, what we're suggesting is that the acute medical take is centralised onto Gloucestershire Royal, alongside emergency general surgery and trauma. And some of those specialties I'd already mentioned have been centralised on there. So the hyperacute stroke unit, for example, and paediatrics. And you start to see the co-location of all these emergency specialties kind of bring to life what I meant when I said that, that 24/7 support, services working together to provide that rapid diagnosis, stabilisation, and then treatment, so we can improve outcomes, reduce recovery times. You'll also see interventional hub, what we call image-guided interventional surgery. That's a developing area of medicine where they use cameras to deliver less invasive surgery. So historically, where you may have had open surgery, which would have resulted in a stay in critical care and a length of stay within one of our hospitals. This new technique is less invasive, so it means recovery times are lower, it means stays in critical care are lower, and it means complication rates are reduced as well. So the proposal here is to create that 24/7 hub on the emergency site to provide that service alongside vascular surgery. So vascular surgery is an emergency specialty that has interactions with IGIS, for example, and the other areas. So we're suggesting that vascular surgery is also on the Centre of Excellence for Emergency Care. And then over on to Cheltenham General, what we're saying is gastroenterology. Some of you might be familiar that gastroenterology has been running as a pilot for the last 2 years over at the Cheltenham General site, and we've seen huge benefits for patients and staff of running that model. So now this is about making that permanent. We want to do more day case general surgery at Cheltenham General to have that reliable access to theatres. We want to do elective orthopaedics on that site, and we also want to maintain an image-guided surgery spoke, so that will provide continued support to services like urology and oncology, for example. So those boxes are in red. Having gone through that 2-year process, there's only one option that we're consulting on, and that's the ones I've just talked through. And when it comes to elective inpatient colorectal, the work that we've done has meant that we couldn't agree on a preferred option. So we're asking for views from the public on what their preference is. So the case for locating colorectal surgery at Gloucestershire Royal is really strong because it's on an emergency care site, and it would be alongside emergency general surgery and upper GI, for example, and those services work together. So you could locate it on the emergency site, but you also could locate it on the planned care site. Again, there's a strong case for it to be on the same site as gastroenterology, for example, urology and gynae-oncology. So our teams have a mixed view on where that could be. Both models are innovative and improve what we would do now. Both are deliverable. So we wanted to use the consultation process to just hear what public thought about where that one should be located. So that's an overview to the overall Fit for the Future programme. And as I said, today we're going to focus more on the acute medical take element of that. So we'll start by playing a short video just to explain a bit what acute medicine means. And then afterwards, I'm going to hand over to Ian and Rod just to tell us a little bit about some of the benefits of that model. And then we'll go into some of the questions. So if we can play the acute medicine video, please.
Acute medicine services work alongside but are separate from the emergency departments. Patients can be referred here by their GP, paramedics, senior community nurses, or from the emergency department. They provide assessment, investigations and treatment for patients with particular complaints such as breathlessness, severe headache, chest pain or frailty. The acute medicine team coordinates initial medical care, whether you need a hospital stay, also referred to as the acute medical take, or are able to return home after assessment and treatment.
We are facing many challenges, but we believe that there are opportunities too to enable us to provide the best possible care for our patients. Patients are not always seen by senior doctors as quickly as they could be. Rising demand for the services and increasing numbers of people with more complex needs means our patients often need to see different specialties when they are in our hospitals. We are struggling to recruit enough medical and nursing staff to fully staff both hospitals and meet the needs of all our patients. We need to timely communicate our decisions to primary care. We need more space to follow up discharged patients in an outpatient clinic-like environment. Our preferred option to achieve all this is to centralise the acute medicine take at Gloucester Royal Hospital.
Cheltenham General Hospital would continue to have a consultant-led A&E open 8 a.m. to 8 p.m. and a nurse-led service from 8 p.m. to 8 a.m. 7 days a week, providing a wide range of emergency services and able to resuscitate, stabilise and treat patients as required. Walk-in patients would be able to access the service as before. Many patients attending A&E can be diagnosed and treated the same day and return home. Sometimes this involves coming back to hospital for a follow-up appointment at either Cheltenham or Gloucester hospitals. If you are assessed by the clinical team at Cheltenham Hospital A&E or Gloucester A&E, need a hospital stay and can safely go straight to a specialist ward at either Cheltenham or Gloucester hospitals, you would continue to do so.
If your diagnosis is uncertain and need to be assessed urgently by acute medicine team, you would be taken to Gloucester General Hospital if not already there.
By making changes, we can ensure patients are able to see the right specialist first time and receive a more timely assessment, diagnosis and treatment when they arrive at hospital. We will also be able to attract more staff and provide more robust cover 24 hours a day.
We believe that these changes can offer safer care for the patients. By concentrating staff, doctors, nurses, physiotherapists and clinical staff at Gloucester, we can optimize our service provision to provide a world-class acute medical unit.
Visit www.onegloucestershire.net for more information. Register with our new engagement platform where you can share your views, experiences and ideas about local health and care services. getinvolved.gloss.nhs.uk.
Great. Okay, so hopefully that gave you a brief introduction into what we mean by acute medicine. So Ian, I don't know if you just want to cover the next two slides, which is around current service provision and then what we're proposing, and I'll just move the slides on.
Yeah, thank you, Simon. So acute medicine, it's probably helpful to explain what acute medicine is, I think, before we perhaps go into this. So acute medicine is a specialty in its own right. It sits alongside emergency care. So it sits close to the emergency department, but really provides care and support for patients presenting with an emergency situation where they need medical treatment. So that's not something that'll end up with an operation or a broken bone, but it's things like a heart attack, a stroke, a severe chest infection, a blood clot, an acute neurological problem, so paralysis, these sorts of things. So quite significant illness. We have quite high volumes of attendance with those sorts of conditions each day across the county, and it's that group of patients that we're talking about the care for. And we have a specialist group of physicians, as you've heard in the video, who look after these patients. So right now, and as this slide shows, what we have is provision in Gloucester and in Cheltenham. So we have what we call same-day emergency care. So sometimes that gets called ambulatory care. So that's for patients who are slightly less acutely unwell, who can attend for assessment and have a decision made about whether they need to be admitted to hospital. And sometimes they can be managed as a sort of as an outpatient basis, but as an urgent outpatient basis. And then we have our admission units, and we currently have those both in Gloucester and in Cheltenham, and those are called the Acute Medical Unit in Gloucester and the Acute Care Unit in Cheltenham, just to avoid confusion. Linked with the Acute Medical Unit in Gloucester, we have what's called the Frailty Service, which is a service that supports patients who are generally elderly with other complex medical problems and are frail, sort of, so that they're not usually quite so acutely unwell, but they just have a general decline and deterioration, and we have experts in dealing with that. And we have our stroke service in Gloucester, but the rest of the services are balanced between the two sites, and really you can present to either site with either any of those sort of conditions I've just described and be looked after at the moment. That's the sort of model we've currently got. So what we're proposing is to really not make any huge changes to the same day emergency care part, so that walk-in ambulatory service. So it's really important to say that that would still be available on the Cheltenham site, and in fact we would be slightly extending the hours of provision of that on the Cheltenham site as a result of what we're proposing. But we would be talking about the admitted part, so the bed part, if you actually have to come into hospital with an acute medical problem, to centralise that onto the Gloucester site. And that would include the frailty service and the stroke care part of that. So that would be on the Gloucester site. It's very important to say that we wouldn't be affecting the ward base, so we would still have medical wards on both sites. And as you know, the emergency care, the ED department, the emergency department isn't affected by this. But it's really that centralisation of the admitted part and the benefits that that gives us to have that critical mass of centralised expertise that we're talking about here. So in terms of the sort of rationale for this, if you like, I mean, we are facing an increasing demand of admissions. Numbers have been going up. You know, I've been a consultant in Gloucestershire now for 18 years. So it's, you know, the medical take, which is what we call these patients who are admitted acutely, has increased significantly over that time. That's also coincided with increased specialisation. So we have, you know, subspecialisation even. So we have much greater expertise at a very specific level, so the expertise to deal with very specific conditions, and we can do more for patients. So, you know, when I was a junior doctor, we treated heart attacks by, well, giving them blood thinning clots. We now treat heart attacks by procedures where we open up the arteries invasively, and that's just changed over time. So very, very different approach to how we manage these things, needing much greater expertise. So the benefit of having that in one place is helpful. And we need to be able to do that. We need to have the resource, particularly the senior medical resource, available to provide that expert care. So that's really what we're proposing here, is to centralise, to be able to get the specialist care around the clock, so the 24/7 around the clock of those super specialists who can give the treatment you need. As Simon said in some of the introduction, that will mean repatriating work that currently goes out of county, so bringing back our acute heart attack service, so patients don't have to go down to Bristol to have their coronary arteries opened up overnight. That was part of the proposal here, so we'll be bringing back work, but we can only do that by centralising. For staffing, that will obviously have advantages, which makes it more attractive to be working in that big centre of excellence, and we've got that opportunity with our 600,000 population to do that. So that's really what we're consulting and proposing around here. Thanks, Colin.
Good. Okay, thanks, Ian. So just to reiterate then, so this is about creating a centre of excellence for acute medicine at the Gloucestershire Royal Site, and I think as we've been clear, the A&E department at Cheltenham is not in scope of this, and it will revert to its pre-COVID state. So we've had a number of questions come in as we've been talking. So I think if I would just crack on and work our way through those. I know one of the team is keeping an eye on Slido as well, so we'll add these questions in. First one, if I come to you, Rob, Ian touched on this slightly, but there's a couple of questions around, I think it's a bit of confusion around what do we mean by same day emergency care and how is that different to an A&E? So I just wonder whether there's a few examples you can help bring that to life a bit.
So, yes, of course, it's the same day emergency care. So if you've had cause to come through our departments over the last year or two, you might have come through an AEC unit, an ambulatory emergency care unit. So it's that service we're describing. This is the same day emergency care is the language that we'll hear now around the whole of the NHS. and it recognises that not every patient who attends hospital needs to stay overnight, even if they need more complex investigations and follow-up. So the examples we've talked about in the past and heard about in the video is if you perhaps present to one of our departments breathless and you have pain in your chest that is worse when you breathe in, then one of the things that we might be concerned about is a blood clot on the lung or a pulmonary embolus. That is treated medically with tablets, but in order to establish the diagnosis, typically patients will have a blood test first and then a CT scan, and then we'll need the results of that CT scan discussing with them and the details of the medication they would need. And this is one of those successes of our same-day emergency care service, because whereas a few years ago, that is a condition where you'd be admitted into hospital overnight and spend a night or more in hospital, this is something that we very commonly manage through arriving at the emergency department and going through to a same-day emergency care unit where there is a specialist team who is set up to identify the problem you have, organise that blood test and that CT scan as needed, and advise you of the results, and get you home either that same day or get you home overnight so that you can come back the following day and not have to spend a night in hospital. So that's an example of a sort of a pulmonary embolus that you would have stayed in hospital for, and now no longer is that the case if we have a well-functioning same-day emergency care department.
Great, thank you, Rob. Ian, if I come to you, there's a question around medical cover at Cheltenham. So I think if we, just a bit of an explanation, if we move the acute medical take to Gloucestershire Royal, what would the remaining medical cover be at Cheltenham General? Can you just explain that?
Yes, thank you, Simon. So I think the main thing that to stress is that we will continue to provide that same-day emergency care service. So we'll have a consultant provision to run that in the hours 8 till 8. But outside of those hours, we'll still have full medical cover for all the wards and the service there, and that will include a resident medical registrar. So that's a fairly senior doctor who's close to completing their training, who's able to be resident all night, and that's the current provision we have at the moment. So we can provide that backed up by a full on-call consultant service. We'll also have the intensive care, the critical care as we call it now, but really the intensive care support. So we'll have senior anaesthetists available and a team there. But the provision is basically will be the same as we've got now, with the extension of the medical consultant on the critical care and on the same-day emergency care service for a longer period. But the junior doctor support right up to that senior registrar level will be the same as it is now. So that means we can support all of the other services that we are describing as being in Cheltenham under this model, including gastroenterology, which we're consulting on now.
Great, thanks. There's a similar question, Rob, maybe you can help with it. Sort of asking, how will ED staff continue to have access to the other specialist opinions? And so medicine was one, general surgery is another, and paediatrics. I just wonder if you could help bring that to life. What do you do if you need a specialist opinion, Rob?
So there will be some specialists still available, depending on the outcome of the consultation. So the first specialist I perhaps go to for assistance might be one of our radiologists to advise what sort of imaging might be required for a patient's care, and those imaging services will still be available in Cheltenham. And then it's a well-established system where we can call an on-call specialist by telephone, but then with a shared medical record and shared computer system where we can look at the same blood test findings, the same x-rays or CT requests, and the same patient care record. That can be done remotely very well by telephone. And where needed, a specialist can come to the patient, or we move the patient to the specialist. So it's already been the case, for example, if I am working in Cheltenham and I see an unwell child, where our paediatric specialists are in Gloucester, and that system works well.
Great, thank you. There's one that I'll take. So how will GRH cope with the increased activity and demand? So just to say this, kind of covered in my introduction, this is about a strategy for the next 3 to 5 years. So it will take a couple of years for us to fully implement all the proposals that we're talking about. But the purpose of agreeing a strategy up front is that once we've got that secure and agreed, then we can make operational decisions to bring it to life. So you're right, to implement this fully, we may end up needing additional ward capacity at one site and additional theatre capacity at the other. There may be some additional or new workforce roles that we want to attract into the hospital and train. But we need to get the strategy agreed first, which is what this program is looking to do. And then we can make decisions around estate, kit and equipment. That's another good example about trying to avoid having expensive equipment on both sites. Let's agree where the service is going to be, and then we can make sure we get the latest equipment on one site to support the teams. And again, around workforce attraction, retention and training. So strategy first, get that agreed, and then we can make operational priority decisions to implement that. But it's looking at an implementation timeline, probably over the next 2 to 3 years, that we will bring this to life. Another question for you, Ian. One person saying, how is it better to have one very busy acute medical unit? Isn't it better to have 2 less busy ones?
That's a good question. I think it's about the bit I tried to explain when I talked earlier about the centralisation of specialty expertise. So we can plan to staff a busy unit with the right number of staff. So the ratios of staff to patients can be the same or actually better than we currently do, having to stretch that across 2 sides. But we can pull the expertise centrally. So we can have more senior consultant presence, for extended hours than we have if we have to split that across 2 sides. So that means that the patients can be seen more rapidly by a senior decision-making consultant or senior registrar type role. We can get the expertise. So I'm a gastroenterologist. If a patient comes in to the acute medicine and they have a intestinal bleed, we can provide that service very rapidly for them by that presence, and we can do that because we know that's predominantly one area where they're likely to present, and that's how we can manage it there. And that's the same for the other specialties. So the cardiology service, for example, if the imaging service we're talking about is present in Gloucester, if someone comes in with a heart attack, they'll be rapidly able to access those facilities. Whereas at the moment, it's very difficult to provide those split across the 2 sites. So that's really the benefit of it. The volume part, absolutely, I agree with. We have to scale up our services to provide that. But of course, we can do that if they're in one place. And we just address that and respond to that. Thank you.
Great. Thank you, Ian. There's a familiar question here. Why don't we just build one hospital in the middle of the 2 sites? So if I just cover that, and Rob and Ian, you might want to comment as well. So looking around where other trusts have done that, it probably takes 10 to 12 years from the idea through to opening that hospital. And we don't want to stand still for another 10 to 12 years. So this is about, as I said, that strategy in the sort of short to medium term. Even if, and we've looked at it before as a trust, and it's close to £1 billion to create a single hospital somewhere in between the 2, Gloucester and Cheltenham. But even if we had all that money, we're not clear that we would just have one single hospital. So I think the benefits of separating emergency care and planned care are really strong. So we may, and that would be the bit we'd need to explore as part of that programme. So we're not saying no to that. And some of you may be aware, in the Gloucestershire 2050 vision, there is a statement that says there will be a new hospital for Gloucestershire by 2050. The scale of capital to do that, as I said, close to £1 billion. We don't see a route to accessing that level of capital within the short term. That's not to stop us applying for it if it did come up. But this is about the here and now, making best use of our sites in that interim period, and making these strategic decisions so we can make sure investments are in the right place. So investments in estate, equipment and people are all in line with the strategy. Is there anything you guys would add to that, Rob or Ian?
No, just to wholeheartedly agree that that's the clinical perspective, that we are looking to make improvements on a much shorter time scale than that would deliver. So this is absolutely our wish.
Yeah, I would exactly say the same thing, Simon. I think, whilst there are clinicians who think a central hospital in the future may be useful, I think there are ways we can get there much faster with what we're doing, and that centres of excellence concept works really well. So I think, actually there are some benefits to having we're lucky we've got the two big hospital sites close to each other. We've got the critical mass of 600,000 patients, so we can really utilize that to its maximum whilst not ruling out that longer term possibility you've talked about. But yeah,
good. Okay. There's a bit of a detailed question come in on Slido. So Rob, I'm not sure whether you can bring this one to life a bit. Is what proportion of patients that come to ED are not actual emergencies, so they could be treated at home by a GP or pharmacist? I don't know whether you want to talk a bit about our admission rate and the number of patients that actually we treat on the day, don't we? And
yes, happy to talk about that. So it is true that if there is another service that has the capacity and the right skill mix of members of staff in it, then there could be an alternative for many patients who present to the emergency department. I'm being careful because I don't want to criticise people for coming to the emergency department, because it is still the case that for the majority of people who come to our services, that is the right place to be. But the studies, and you'll see different numbers quoted, but the Royal College of Emergency Medicine position from their what they call a sentinel site survey suggests that perhaps somewhere between 15 to 20% of patients who would currently attend emergency departments could be cared for in another setting if the service was available. So it's important to remember that there is a proportion that could receive good care outside of the emergency department, and that's a proportion that would make a significant impact onto the space that's available, the staff that we need to provide in the emergency department, and those are the sorts of numbers we're talking about. Emergency department is busy, but I would remind people also that our GPs are busy throughout the county. The emergency or sort of unscheduled care, so unplanned care in Gloucestershire, is delivered by a whole host of people, including GPs, minor injuries units, etc. And work is ongoing to try and make sure we get the right person to the right place at the right time. And it's maybe 15 to 20% of the patients in ED that we could be able to get them seen elsewhere.
Great, thanks, Rob. One question, Ian, around how would this be better for staff? I just wondered whether you wanted to talk about training support and that sort of stuff.
Yeah, absolutely. So I think it's about the scale, isn't it? So I think what you went at the moment, we have to staff to full medical takes on both sides. That means significant staffing on splitting, and the rotas to do that are more complex. So the frequency of nights and the number of staff we can put on there are difficult. The supervision, as you say, in terms of training is more fragmented because we haven't got such senior presence around so many hours of the day. So the most of the trainees get their training from their senior doctors present. So by having it in a big scalable unit where we've got more staff on with more seniors, there's greater training opportunity. There's a greater sort of morale boost for being part of that bigger picture. We've got that centralization of experts that I referred to. So there's all of those benefits really that make staffing this more attractive. I mean, I think I would stress this isn't being designed for staff. This is about quality of care, but those staff benefits make it more attractive, so it's easier to recruit. So ultimately we get our caliber of staff we can maintain and continue to recruit at a very high level, which I think is one of the additional benefits of this. So yeah.
Great, thanks, Ian. Okay, I'm going to just cover some of the slides in terms of the consultation process. I can see a couple more questions coming in on Slido, so let me just do what's the consultation process going to be, and then we'll cover the last couple of questions. So in terms of who are we consulting, this is part of a number of events that we're running to hear feedback and help people understand the proposals in a bit more detail. But we are in sort of listening and understanding mode now. So things that we pick up will help us make a decision in March, which is when we are looking to take all the feedback into account. But we're trying to make it as broad as possible. So clearly we're in a pandemic. So we deliberately designed what we call a socially distanced consultation. So for example, times gone by, this sort of event would have been in a probably quite a chilly village hall or a community centre somewhere. But we're doing them online, and the ones that we've run so far, so this consultation process began on the 17th of October. The numbers of people accessing online sessions such as this in a live, so here and now, but also then watching it afterwards on YouTube and on Facebook, we're into the thousands. So historically we would have got 10, 15 people into community centres to listen, but we're really pleased in that the reach we'll be able to get people tuning in and listening and sending questions in advance, for example. So more of an online approach we're taking for this, and there's sessions like this, there's the films, they're all available on the Get Involved Gloucestershire website. The booklet that's out and about, it's been distributed across the county. We are running telephone interviews, so in that booklet, if people don't want to complete the survey either in hard copy or online, they're able to leave a message and we will phone them back and capture their feedback that way. Within the hospital sites, we're using online events, but we also have socially distanced drop-in events, so people can come and hear about the proposals and leave their thoughts. And thankfully, now we're in Tier 2 in Gloucestershire, we're able to restart the bus tour. So again, travelling around, we were in Wales yesterday on the borders, and we've got a number of events for the rest of December. So people can drop in and give us our views on the proposals there. So there's a couple of websites on the slide that will pop up shortly, just shows the way people can go for to kind of give their thoughts. And I would encourage everyone to complete the survey if they can, please. So last couple of questions, what have we got? The new hospital, if it's a good idea, why don't we start now? So we will. So we're coming out of austerity as a trust, as a country, aren't we? And the level of capital, as I say, to do that in Gloucestershire would be close to £1 billion, we think. When the process to start to apply for that is clearer, then absolutely we'll be on the list. But as I said, we look across at North Bristol Trust. It took them 12 years from idea to conception to get that all the way through. And we don't want to stand still in the interim. So this work is still vital to make sure we make the best use of the two sites and improve outcomes for patients in the interim. So we'll continue to do that. So we will do both at the same time. And the other one was around staff benefits, which I think we've covered in Ian's and Rob's feedback. So thank you for making the time and joining us today. I hope we covered some of the key points. Tell your friends, this is available on YouTube and on our site. So if tell your friends and they can watch it. And as I say, please encourage, if you haven't already, please complete the survey online and encourage your friends and family to do so. And thank you, Rob and Ian, for taking time away to attend today. Much appreciated.
Thank you.
Thank you.
Thanks, Sam.